So there are congenital causes. Some babies are born with hiatus hernias, but most of them develop over the course of life. And I think it's really important to distinguish between hiatus hernia, which is a very commonly known term, and acid reflux, and they don't necessarily mean the same thing. Most patients with hiatus hernia do get acid reflux as well. But what a hiatus hernia means is when there's a weakness in the diaphragm, and the top of the stomach moves through the diaphragm up into the chest, and that can precipitate and cause reflux. But reflux problems and hiatus hernias often do go together, but not always. So to come back to your question, some people are born with an inherent weakness in the diaphragm and have reflux when they're born and have a hiatus hernia. But in most people, it's something that's acquired over life, over many years of perhaps being overweight, perhaps eating a poor diet, perhaps having recurrent problems that lead to increased intra-abdominal pressure. So pregnancy can cause it, for example, increased pressure. If you've got a chronic cough or perhaps chronic constipation where you're regularly increasing your abdominal pressure, that can cause hiatus hernias. So there's a whole host of things, but I think probably the most important thing, other than the group who are born with these problems, a lifestyle, and that involves being overweight and perhaps eating a poor diet. So we treat hiatus hernias in different ways, and again, it's important to distinguish whether it's simply a hiatus hernia or whether there's acid reflux associated with it. The most important thing is to treat the acid reflux, because that's actually those are the symptoms that the patient experiences, whether it's heartburn or food regurgitation, or sometimes food spilling up the esophagus and going into the lungs and causing chest infections. And that can be a really bad problem at night sometimes. And that's what we call volume reflux, where acid and sometimes food spills over into the lungs, causing often pneumonia. So the most important part about hiatus hernia is to treat the underlying reflux. And we tend to do that in most patients with some very well-known drugs called proton pump inhibitors. And many of you will have heard of those. There's omeprazole, lansoprazole, esomeprazole, and a few others as well. There are also drugs you can buy over the counter like Gaviscon, and so-called antacids, which just antagonize the acid and get rid of the heartburn. But occasionally, if those drugs don't work, you have to come and see someone like me, a surgeon who carries out surgery for these conditions. And what we do, we tend to do this in the vast majority of our keyhole surgery, and it involves repairing the hiatus hernia. And in particular, that means strengthening the hole in the diaphragm to narrow that. And then we do something called a fundoplication, which involves wrapping the top of the stomach around the lower part of the esophagus. And that creates a high pressure zone, and it stops acid and food refluxing back up into the esophagus. And it's a really effective way of doing that. It's not 100% perfect, and perhaps 10% of patients don't get a perfect result. So we're very cautious in selecting patients for this sort of surgery, and we do a fairly substantial battery of tests just to check whether the surgery is going to work. And that involves, at the very least, doing an endoscopy to have a look down and make sure there's nothing else going on. But it also involves measuring the amount of acid that comes up into the esophagus during a 24-hour period. And it also involves putting a pressure transducer down on a very fine catheter to measure the strength of the muscles in the esophagus, to make sure the surgery is not going to cause too many problems in tightening things up, because of course that can lead to long-term eating difficulties if it's too tight. It's probably worth mentioning also that the two different types of hiatus hernias. I've really been concentrating so far on the main type, the most common type, which is what's called a sliding hiatus hernia, where the top of the stomach just simply slides up into the chest. And that's the type of hiatus hernia that's associated with acid reflux. There is another type of hiatus hernia, which is usually a much, much bigger hiatus hernia, which is called a rolling hiatus hernia. And that involves often the whole stomach rolling up next to the esophagus and going up into the chest, lying next to the esophagus. And sometimes that can be so big, the bowel can go up with it, or the pancreas or the liver. And that can cause really severe problems in terms of blockages, the stomach twisting. And we tend to have a much lower threshold for operating on those patients. So any patients with a big rolling hiatus hernia that's causing what I describe as mechanical problems, difficulty eating, or the stomach twisting, causing pain, we have a very low threshold for operating on those. Again, I do a lot of those. I do them all via keyhole surgery, often as a day case or a single night in hospital. And even though it's done via some very small incisions in the abdominal wall, what you're doing inside is often quite major surgery, because sometimes you find the stomach, the bowel, other organs sometimes up in the chest, and it can be quite challenging to repair that. It's really important to get these operations right the first time, and I cannot emphasize that enough. It's why we are quite cautious in offering surgery and only offer it to surgery in whom we're convinced there's a very good chance of it working. It's so important to get it right first time, and it must be done by a surgeon who regularly does these operations, because in all honesty, the best chance of getting it right is the first operation. I have a particular interest in doing revisional surgery, and by that I mean surgery for the second, third, or even fourth or fifth time when it's been done before and hasn't worked. So I have quite a big practice in seeing patients from all over the country who've had this done before. Perhaps it hasn't gone as well as they had hoped. Perhaps it had worked well, but it's now come back. And I have a particular interest and expertise in dealing with those patients. I can still do the vast majority of those via keyhole surgery, but occasionally it's very difficult to do via keyhole. And particularly if you're doing it a third, fourth, or even fifth time, there is a greater chance of having to do open surgery. But I would really stress the best chance of getting this surgery right is getting it right the first time. So, the small sliding type of hiatus hernia, we only operate on those when the associated reflux symptoms, like the heartburn or the food regurgitation, doesn't respond to the drug treatment that I've talked about already. So most of these patients with reflux can be very successfully treated with omeprazole or esomeprazole or other proton pump inhibitors. And really, we would only operate on small sliding hiatus hernias when the drugs don't work, i.e. patients are taking these drugs, but they're still getting a lot of symptoms, and particularly those symptoms when they're aspirating or the acid's going into their lungs at night and they're getting chest infections. So if the drugs don't work, there are some patients in whom the drugs work, but the drugs cause side effects. We know these drugs can cause osteoporosis, for an example. So if someone, and this is more common in females than males, but if someone does have bad osteoporosis, that might be a contraindication to taking the drugs, and therefore we may have to operate on patients because they can't take drugs. And in a small proportion of patients who have thought a lot about this, they decide they don't want to take long-term drugs. So particularly maybe someone who's young, is facing perhaps 50 years of taking drugs, even though the drugs work, even though they tolerate the drugs well, they may, with absolute justification, decide they don't want to take drugs for the rest of their lives and they would rather have surgery. So we will certainly consider those. But again, patients needing this surgery is not 100% perfect. About 10% of patients do not get the perfect result. And therefore, it's really important to select your patients properly and to counsel patients properly so they know exactly what the risks, what the benefits of the surgery are, and then make a joint decision with me as to whether it's the right way forward for them. So the sort of things that I've talked about which cause hiatus hernia. So if you're overweight, that will make a hiatus hernia worse. If you have a poor diet, that will make things worse. The main control of acid reflux is in fact a sphincter in the lower esophagus called the lower esophageal sphincter. And that is the main control of acid reflux. We know that that sphincter relaxes excessively if you eat the wrong things. So smoking, alcohol, caffeine, chocolate, rich dairy products, all these things cause the sphincter to relax, and that allows acid to come up. So you can have that without a hiatus hernia, but as I said earlier, the hiatus hernia will exacerbate problems with that sphincter. So if you have a poor diet, that will certainly worsen problems with a hiatus hernia and acid reflux. If you're overweight, if you have chronic conditions that lead to increased intra-abdominal pressure, like a chronic cough or bad constipation, so you're straining all the time. So the hiatus hernia itself, the weakness in the diaphragm won't go away by itself. Once the weakness is there, it's there forevermore. But the effect of the hiatus hernia, the symptoms that are associated with it, can absolutely go away if you modify your diet. And so cutting out things that make it worse, like smoking, excess alcohol, excess caffeine, excess chocolate, cheeses, rich dairy products, all those nice things. And again, I'm not telling you to stop it completely, but if you do those things to excess, then take those things in moderation. That will certainly get rid of the symptoms. But the actual anatomical abnormality of the hiatus hernia won't ever get better by itself. So they can be. I mean, the small hiatus hernias, what I talked about earlier, the sliding hiatus hernias, which really only cause problems of reflux, they're not dangerous. Now, the associated reflux is very rarely dangerous, but very occasionally, if you have bad reflux where food and acid is spilling over into your lungs, that can cause life-threatening pneumonia. And I have seen that, and I do see that. But that's really in rare occasions. I mentioned earlier that the rolling hiatus hernias, the very large hiatus hernias, which can twist, and they can be very dangerous. Again, the vast majority are not, but occasionally, and we do see this, maybe once or 2 or 3 times a year in Oxford, patients who have very large hiatus hernias, the stomach can twist inside the hiatus hernia, inside the chest, and it can become gangrenous and can die. And that becomes a true surgical emergency. So we get patients transferred to us from elsewhere for really urgent, immediate surgery. I really would stress that is rare, but it's why we have a very low threshold for operating on these large rolling hiatus hernias, which can twist. And one indication that they may be more likely to get such catastrophic complications is if they're already getting regular pain when they eat. So if you have a hiatus hernia and you have severe pain when you eat and there's a sensation of a blockage, you really must see a surgeon who with a real expertise in dealing with these, because we have a low threshold for operating on these to prevent that very rare but potentially catastrophic complication. So achalasia is an uncommon disorder of the esophagus, and it's where the muscles become paralyzed in the esophagus. And that's usually because the nerve cells degenerate. We don't really know why it happens. We think it's probably the body's own immune system is attacking the nerve cells in the esophagus and stop the muscles work. And that causes 2 problems. It means in the main body of the esophagus, which is a muscular tube going from the throat down to the stomach, in the main body of the esophagus, it loses its ability to contract and push food down. And the second effect is that the sphincter, the lower esophageal sphincter, which is at the bottom of the esophagus, and that's what controls reflux or not, that goes into permanent spasm and doesn't allow the esophagus to empty very easily. So food and water build up in the esophagus and only go through into the stomach when it gets such a high pressure, it forces the sphincter to open. So the effect of this condition is that it causes increasing difficulties eating with food sticking. People can often lose a dramatic amount of weight, and the food and the water stagnating in the esophagus can reflux up. And that's in many ways why sometimes patients think they've got a hiatus hernia or reflux, or their primary care doctors think that quite reasonably. And so most of these patients end up being treated with omeprazole or other drugs, but they don't work, because the major problem is the esophagus is paralyzed. And that really does need to be seen and treated by a specialist surgeon like me. I have a particular interest in treating this condition. And even though you can't fundamentally alter what's gone on in the esophagus, you can't restore the nerve cells, you can't restore the muscles to normal activity. What we can do is either put a balloon down into the lower esophagus and stretch the sphincter to open it up, or more successfully, and this is something I particularly specialize in, I do a keyhole operation as a day case when I divide the muscles over the lower part of the esophagus to allow it to open up and to allow the esophagus to empty. And that it's one of the most rewarding operations I ever do, because you see patients who have profound difficulties in eating and drinking, have often lost 10, even sometimes 20% of their body weight because they cannot get food down. And you do this operation, you divide all the muscles that are in spasm, and they wake up and they suddenly say, God, I can drink, I can eat, and it can be life transforming. So it's probably the single most rewarding operation I do. Again, it's a bit like hiatus hernia surgery. It's really important you get it done by someone who does this operation regularly. It's not a common condition. It really isn't. So most surgeons who do it may only do one a year. I do many more than that. And I think it's one of these operations where the more you do, the better results you get. So it's really important to come to someone who does it regularly. And although that can last a lifetime, about 1 in 4 patients we treat do run into further problems, and further intervention is required. And again, that needs to be seen by a specialist surgeon who deals with recurrent problems with hiatus hernia and recurrent problems with achalasia on a regular basis.